And we are going to roll. We're going to roll right into our last presentation. This is a 90-minute presentation. Colleen Stephenson is going to speak to us on Mouths Matter, inextricable link between oral, mental, and physical health. Colleen Stephenson is a clinical associate professor in Idaho State University's Department of Dental Hygiene, where she serves as the community outreach coordinator and teaches courses in community health and special needs populations, community and global health, and prevention and management of medical emergencies. She has served in numerous professional leadership positions, most recently as the chair-elect of the Idaho Oral Health Alliance. She also serves as the oral health champion for the Idaho for the 1 Million Mouths campaign led by Harvard School of Dental Medicine, and other collaborations from the Center for Integration of Primary Health and Primary Care and Oral Health. This talk is co-sponsored by the Idaho Oral Health Alliance. Welcome, Colleen.
Hi, everybody. Thank you. Thank you for having me today, and also thank you for not putting me in the 7 a.m. slot. You guys are early birds, so I was glad not to have to get up that early. So I'm excited to be here today. As she mentioned, I kind of am a jack of all trades and a master of none, but through a lot of my work, I get to come and kind of share tidbits about oral health and try to work collaboratively. So thank you for staying, because I know this snow has made for a beautiful afternoon, hopefully. So I wanted to tell you quickly about the 100 Million Mouths campaign. That's the primary reason that I'm here today. So basically what it is it's an initiative that was created where they recruit oral healthcare champions through each of the 50 states. And the goal is to be able to create 50 within the next decade. I believe the first cohort was in 2021, I believe. And they do it with a few at a time, basically. And it's a whole mishmash of professionals. So most of the people in my cohort are physicians, a lot of pediatricians. Is anybody here in pediatrics? Not a whole lot. Oh, maybe a couple. So a lot of pediatricians, obviously, they have a vested interest in oral health. That's something we're really pushing. We have nurse practitioners, PAs, other dental professionals. In my cohort, there's one other dental hygienist. We have one dentist out of Hawaii, but most of them are medical providers. And basically, our job is to train people about why mouths matter, why oral health is important, and trying to especially focus on people who are in the education process. So we're looking at people in med school, residents, and things like that. And then we are trying to essentially be able to improve the health of at least 100 million mouths over the next decade. So that's the whole purpose behind that initiative. And that's the big reason why I'm here today, is because they like us to be able to talk about this. And it's a good thing. It's something I'm already hot about. So thank you for having me again. So to kind of understand how we've gotten to where we are, we have a picture from one of my favorite movies. Does anybody know what movie this is? Dirty Dancing. Those of us born in the 1900s, that was a real blow to my ego when I got ID'd one day and they said, she just glanced at it. I was like, oh, is it because I looked old? Or she said, oh, I could see that you were born in the 1900s. Like I was born in a covered wagon across the plains, like my pioneer heritage. So any of us who were born in the 1900s, and I like to think those of us who were born after, and by us, I'm speaking loosely because it's not me, can understand this movie. And so I also wanted to say quickly is that I like to have more of an interactive presentation, especially I know some of you have been here since 7 a.m. And so if at any time you have a question, please raise your hand, please chime in, because I'm not a medical provider. I am an oral health care provider. And so if you don't understand anything that I'm talking about, like please ask the question, because you're probably not the only one with the question, okay? So anyway, my favorite movie, this is one of the best scenes, right? So this is kind of how we've gotten here. And when I think about the way that we've had education for medical and dental, is we've kind of been like, this is my dance space and this is your dance space. And you don't go into mine, I don't go into yours, and you don't come into mine. And that's the beginning of the movie, and that's kind of how we've gotten here. So interestingly enough, dental education actually was started by physicians. The first dental schools were started by physicians. But we've kind of had this separation into siloed healthcare where we don't go into each other's dance spaces. And it's something that's really been reinforced through legislation, our education, and of course, our service delivery. So this is how we got here, and where do you think it's gotten us? It's gotten us here. Has anybody seen a mouth that looks like this before? Unfortunately, me too. And in fact, this is a lot of what I see. So it's gotten us to the point where dental caries remains the most prevalent chronic disease in both children and adults, despite being largely preventable. And this is a whole mishmash of diseases. We'll talk about these a little bit later. So obviously, we can see that things aren't working, right? Here in Idaho, I like to think that we're superior in Idaho. I'm born and raised in Idaho. I grew up in Ingham, south of Pocatello, if you're familiar, the metropolis of Ingham. It is something that I will say we are above average in. So that's one way we are above average, because in Idaho, 66% of third graders, by the time they're in third grade, have had a cavity. Well, the national average is about 46%, just under 46%. And that's for kids ages 2 to 19. So how old are third graders? They're like 8 and 9, right? So add another decade on that, and they're still well below our average here in Idaho. There's a multitude of reasons for that, and we can talk about it later. Adults in Idaho, we're still a little bit above average. The national average for periodontitis in adults is about 42%. We're at about 43%. And really kind of the saddest thing in Idaho is that we only are meeting the dental needs of about 47% of our population. So over 50% of people in Idaho aren't able to get access to dental care because they live in a dental health professional shortage area, dental HIPSA. So I'm telling you that oral health is important, and it's not like this is brand new news to anybody. I think we can all agree oral health is important. I'd never said it wasn't, except that that is kind of how we've thought about things. So in 2000, the Surgeon General released their report about oral health in America, and this was a groundbreaking report. And it was a big deal, especially for dental professionals, because we were like, it was the first time that somebody said, hey, like, oral health is important, and you can't be healthy without oral health, and we need to stop keeping our separate dance spaces here and have a siloed approach to care because it's not working how it is. So they're saying it's a critical component of health, and it has to be included in the provision of healthcare. And so one thing I try to teach my students in my courses is I try to hit them hard. I'm working on it on my end, guys. I try to hit them hard with, you are a healthcare provider. I don't want you to say I'm just a dental hygienist. I don't want you to say I'm just this. You're a healthcare provider, and we have to work together to be able to make a difference. And so they get hit hard with that all the time. I hit my other colleagues with it all the time. I'm hitting you with it now. So when we talk about the Surgeon General's report, that was out in 2000. In 2003, they had a call to action where they're like, okay, we gave you all this information, gave you a few years to digest it. Now let's do something about it. That was in 2003. We had an update in 2021, and they called it Advances and Challenges. And I love that they tried to frame it positively, like, hey, maybe we made some work on this, but essentially what the report says with the advances and challenges is we haven't gotten very far in 20 years, and we're kind of where we've been to begin with, although we have made a few advances. So when we talk about how oral health is a part of total health, we have to kind of understand how these things are related. And probably the most simple way for me to state it is that your mouth is connected to your body. Your mouth is a part of your body. It's not like we just carry it around and take it and do separate things with it, and we treat it separately. It's part of our body. It reflects what's going on in our bodies, just like other things can be reflective of that too. So when we try to talk about these different links between health, what we found is that there's probably what we call a multimodal relationship. So there's certain things, like our last speaker was speaking about diabetes, right? And so we know that with diabetes and oral health, there's a bidirectional relationship. So we're not going to get good diabetic control without control of periodontitis, and vice versa. There's other relationships where they think perhaps there are obviously environmental factors. So when somebody's stressed, we know what that does to inflammation in our bodies. And essentially when we're looking at these links, a lot of the links are inflammatory. They're inflammatory links based on infection, but there's so many other things that come into it too. We can also have things like parafunctional habits, so like clenching or grinding. That does bad things to our mouths. Don't ask me about it. My front teeth have been a little loose from clenching so much, and I know better. We have basically different medications, especially where we are seeing older adults. Remember, our baby boomers are aging, and so we're seeing a lot more people. They're living longer. They've had oral health care throughout their lifespan, and so they're keeping their natural teeth longer, which is a great thing in a lot of regards. But then we're also seeing the effects of things like polypharmacy on the oral cavity, which we'll talk about briefly later. So what we've kind of basically realized is that there's multiple comorbidities, lots of interrelationships and connections, and we have these predisposing or precipitating factors in a susceptible host, and that's how we get disease, and oral disease is part of that as well. So I like this little graphic because it has some little brief things about different specific diseases that can be connected to oral health, but this is really my soapbox statement right here. So I like to use the word infection. Why do you think I like to use the word infection? I'm hearing a lot of whispers. I'll tell you why I like to use it. I like to use the word infection because it's an action word. If we had an infection anywhere else in our bodies, would we leave it untreated? We wouldn't just be like, hope everything works out okay for you. Go home and brush. Get a new toothbrush if you get sick. So periodontal disease and dental caries, they are infections, and we need to treat them as such. We have to treat them. So why should the mouth be any different? It shouldn't, basically, long story short. So in the US, what we do also recognize is that people are more likely to see a primary care provider than they are to see a dental provider. This, again, is too deep. This is top level today because we have a limited amount of time and we're talking about a whole lot of subjects. But basically, with our healthcare delivery system, you guys are the ones seeing the patients more than we are. So like I said, I'm working on it on my end to try to get those relationships, but we need to recognize that oral health is part of primary care. And we have to recognize also that we have to work together to address the disease. So the first step is education. So let's talk about my movie Dirty Dancing one more time. When did things really get spicy in that movie? When they got into each other's dance space. That's exactly it. So we're gonna start dancing. I will not dance for you because that's my gift to you today, is I won't actually dance, but call me later. We'll see where the day goes. So we're going to focus on a few different objectives. These are objectives that I've specifically decided. These are things that we can use so that you can take action in your daily practice. So we're going to talk about some common oral health considerations, things that you can look at and be aware of, and things that you can, do about it. We'll talk about some things you can do in office treatments, simple things that anyone could do. They're evidence-based recommendations. And then I'll talk about a few more oral health resources. So if you want to learn more, and you want to access things, I'm assuming Ada County, everyone's kind of Boise area. So I did do some research. I'm from Pocatello. I'm from Southeast Idaho. So I do have friends and colleagues in the Boise area. It is essentially the metropolis of our state. Income is not. I know that's a shocker to some of us, but we'll talk about some of those things that I've found for your area too that hopefully can be a helpful resource for you too. So when we talk about age, we're going to break it down basically infants, toddlers, children and adolescents, adults and older adults. We will have some medical conditions kind of interspersed throughout there because a lot of times these medical conditions can occur in various ages. So we'll kind of put those in as well. And then these are the medical conditions that we'll specifically talk about, or conditions like pregnancy, cancer, chronic diseases, and mental health. So let's start with pregnancy because, that's how we all kind of start by getting here. When we talk about pregnancy, we know that the number one issue with neonatal morbidity and mortality is preterm births. Does anybody remember reading about preterm low birth weight babies and how there was a connection with oral health? This was several years ago. Again, I was born in the 1900s. Delta Dental had billboards about it. It was like a big deal. Anybody remember seeing those? So those were a big deal thing that kind of came out. And we are seeing that there is some connection with those things, but it's not necessarily a full causation type connection, right? So what we have found, it's logical when we look at all these different things together that we can say it's logical to consider that treating periodontal disease, periodontitis, so periodontal disease includes gingivitis and periodontitis. We don't need to get into the super weeds with it. Basically, one affects the bone, one's just the gums, but we lump them together under periodontal disease. But it's logical to think if we treat these, which is a source of infection, that we might have better birth outcomes. And unfortunately, the current research does not support that. It doesn't say, what it does say is that basically it's still good to get the treatment. The periodontal disease does improve with treatment. It's safe to have dental care at all stages of pregnancy. I'm talking from the beginning to the end. I'm talking all stages of dental care. It's okay to do local anesthesia. It's okay to do, so getting people numb. It's okay to do radiographs. That's totally safe. It's safe in all stages of pregnancy, but it does not appear at this time to improve pregnancy outcomes. So the question is, why doesn't it seem to improve pregnancy outcomes? And there is a school of thought that says maybe by the time somebody's already pregnant, it might be too late to prevent the inflammation and the colonization. So that's kind of where that train of thought has gone. So we're going to start with people before they become pregnant, right? The best time to address a problem is before it becomes a problem. So when you guys are seeing patients, I would humbly request that you take a look inside their mouths. Is anybody here like OB, anything like that, a few of you? So when you see patients, I can tell you that nobody wants to be asked like the taboo subject, like, hey, when are you going to start a family? I don't want to be asked that by my neighbor, right? Or are you guys going to have any more kids? Like that's kind of a taboo topic, but you're uniquely posed to be able to have those conversations because you'll be asking about things like contraception. So that's a prime time that you can kind of look inside the mouth. You can ask questions. You can look for signs of infection, and then you can incorporate discussions about oral hygiene and maybe link those things together if they're interested at that time. So you can ask like, how often do you brush your teeth? What's your diet like? You can ask those types of things when you're in those appointments. When's the last time you saw a dental provider, a dentist or a dental hygienist? And you can discuss why oral health is important and then have a referral system in place so that if you notice any issues, they can follow up on them. So then we become pregnant. So after conception, then we still have the same things that we'll consider during preconception, but we need to recognize that pregnancy can be a great motivator for people to make positive changes. So that's maybe a good time for us to be able to have those conversations because people are more receptive to it, right? Because it's not just about themselves anymore. So they're like, oh, especially if it's a a really wanted and cherished baby that they're trying to build here. So it's important to talk about those same things that we talk about with preconception, but we can also say, again, dental care is safe. And not only is it safe, but it's necessary. It is important to get things taken control of ahead of time because we want to have better outcomes for this baby. Now, when we also see these pregnant patients, I will tell you that if I had $1 for every time I had a patient tell me, well, the baby took all the calcium from my teeth, and that's why my teeth are a disaster, I would have been able to take a private jet here instead of flying from instead of driving from Pocatello in my Toyota. Okay, so I hear this all the time, and that is a misconception. That is not accurate. Yes, the babies do their best to get what they need, obviously, but they're not taking the calcium from their teeth. The teeth were a problem to begin with. That's not why you have a bunch of decay. So if you hear a patient say something like that, you can say, well, actually, did you know this, or this? And you can talk about things like diet. You can talk about risk factors for cavities. So does everyone here or anybody feel brave and want to let me know how a cavity occurs? Does anybody know how cavities occur? We're going to talk about cavities a lot. And I thought, does everybody actually know the process? Take it.
Bacterial dumpling. Well, have food reserves there, bacteria then consume the food reserves, enzymes and such are produced to break down the enamel.
Basically, that was very good. So he said, I don't know if I can repeat exactly what you said, but he was basically right on track. So in a very simplified way, for our friends on Zoom, the way that cavity occurs is we have bacteria in our mouth. Everybody's got bacteria in their mouth. There are specific bacteria that cause periodontal disease, and there are specific bacteria that cause dental caries or cavities. And usually they're just hanging out, having a great time together in our mouths, especially if we leave them undisturbed. And so when we eat, the bacteria break down the food that we eat, and when they metabolize it, they produce waste products, which is acid, and the acid is what causes the cavity. So pH in the mouth is super important because those bacteria really do their most damage and have the best time in an acidic environment, typically, the ones that cause cavities. So when we talk about the way that a cavity forms, it's important to recognize if someone is pregnant and they're experiencing morning sickness, what does that do to the pH of the mouth? It drops it and it makes it acidic, where those bacteria are like, yes, doing their best work. So when we talk to our patients about things like morning sickness, if they're vomiting frequently, you can make recommendations like, hey, don't brush right afterward. Why wouldn't I want somebody to brush right after they vomited? That's a good guess, but no, she said introducing bacteria in the gums. The acidity, it does go back to the acidity. What is the issue there? It hurts the enamel. That's exactly what happens. So we've made our mouth super acidic. We've weakened the enamel, although I will say microscopically. We've weakened the enamel with the acid in our vomit, and then we brush away some of that weakened enamel. So if somebody is getting sick, experiencing morning sickness, we don't want to brush immediately after, although it feels pretty disgusting. And let's go ahead and hit that, right? So you can like tongue scrape, you can rinse with water. You can even do like a baking soda and water mix because that neutralizes the acid. And that's a good suggestion too, but you don't want to be hitting the teeth with a toothbrush. They can chew gum, especially a sugar-free gum that helps stimulate saliva. And saliva will buffer those acids. And that's why diet is so important. So we want to talk about minimizing snacking between meals. I have 2 kids, and both times when I was pregnant, if I didn't eat is when I felt kind of sick. Like I just needed a little snack, a little bit of a nibble, right? But if we're snacking throughout the day, every time we eat or drink anything besides water, the pH in our mouth will drop. And it takes about 20 to 30 minutes for the saliva to buffer those acids. But every time we take a sip or a bite, that clock starts over, drops again, and the clock starts over. So if they need to snack between meals, why don't we choose foods that are a little bit better for our mouths? So we call them in dentistry protective and detersive foods. So protective foods would be foods like nuts, cheeses, like dairy products. Those are great foods. So I have a 4-year-old and he always asks me for a snack after he brushes his teeth. I'm like, why do you do this to me? After he has brushed and flossed. But he is smart enough that he knows the only thing he can ask me for is a cheese stick. You go ahead and have yourself a little string cheese, Cannon, and you enjoy. So because it is a protective food, and I don't really want to go through and brush again because I'm lazy. And not lazy, I'm exhausted and ready for bed too, okay? I've also had a big day. Detersive foods are foods that naturally cleanse our teeth. So that would be like celery. I got room service last night. They really hooked me up with a whole lot of celery. I was like, this is too much celery for one man. Thank you. But I did have a few slices of it. Things like celery that naturally cleanses we eat, things like apples, those kind of crunchy foods. Chips are crunchy food that are not included. Popcorn is not included. So nuts, cheeses, apples, things like that are great for us to have. So you might be having those conversations with your pregnant patients and letting them know also of importance is that hormonal effects. So the hormones, when we see that hormonal surge with pregnancy, we do see oral effects with it also. Basically what happens is our body overreacts to the infection in our gums, to the bacteria that's irritating our gums. And so that's why we'll see like pregnancy-induced gingivitis. The primary etiology in that is still plaque biofilm. The bacteria in the plaque biofilm is still the primary etiology, but the host response is amplified, and that's why we see those types of things. So once that occurs, it's really hard to kind of get them back to a full state of oral health as far as periodontal disease goes, once that's already occurred, and it's because of the hormone levels. It's important to let your patients know, and for you to know also, that when we do see that, those hormonal effects will continue while they're breastfeeding. So if they have the baby and stop breastfeeding, then we're likely to get healthier. But if they continue to breastfeed for at least a year or longer, or it doesn't even matter how long they breastfeed, if they continue to breastfeed, we're going to see those hormonal effects too. So don't be alarmed when they're like, I've had the baby and my gums still look like a disaster. Well, they shouldn't look like a disaster. We should be able to get them pretty healthy, but we might still see some of those inflammatory, like residual effects. Okay. So these are things that you might see when you see a patient who is pregnant. Is there any, oh, what did I hit? The wrong button. There we go. This mouth here, do you guys see anything wrong with this mouth? That's a trick mouth. It's actually a healthy mouth. This is what you want to see. I'm testing you. You guys are sharp today. Okay, so this mouth is kind of what we want to see. I mean, I can pick at it and say, is there a little bit of fluorosis? Maybe they had some coffee stain, but no, I'm not picking on this mouth here in the corner. That's a pretty good mouth. This one in the middle, does anybody know what this is called? Called the pyogenic granuloma. And it's hormone related. It's pretty common. You usually see it between the lateral incisor. So this is a central incisor. This is the lateral incisor. This is a classic textbook pyogenic granuloma. It's basically, it's benign. It's not a big deal. It is something that people can develop when they're pregnant. These are not healthy gums, just FYI. It's more likely to occur when we do have a gum infection. And it's something that won't go away until we lose those hormones that are associated with pregnancy and breastfeeding. This one over here has a whole bunch of things going on. We have some kind of white spot lesions at the bottom. Can you see right along the gum line? That little bit of white delineation. From my angle here, it doesn't look great. It's great on my screen though. Hopefully it's good for you guys. But you can see kind of that white along the gum line. That is what we call demineralization. It's the first step in a cavity. So when we say, hey, you don't brush after you vomit, frequent acid exposures can cause demineralization, will cause demineralization basically. So that's a mouth that also has gingival inflammation. You can see the gums are puffy, they're red right along the gum line. That would be a sign of definitely at least gingivitis or gum disease, and then possibly some early decay as well. This one down here in the corner, you can see the red puffy right along the gum line. So normal healthy mouth, you can see in this first one, the gum tissue kind of looks stippled like an orange pill. And that's how we want it to look. It's the way that the fibers basically attach to the bone. And we don't need to go into all those details, but we want it to look kind of stippled like an orange pill. When we see that it's like shiny and smooth, that's a sign of inflammation. It's a sign of edema. When we look at this one in the middle, again, more pronounced redness, more erythema along the gum lines, and edema as well. And then this is an example of erosion. Now, this would be unlikely to see in someone from pregnancy at this level. We'll usually see it on the maxillary anterior, so the insides of those front teeth on the top. More so in somebody with bulimia, but you might, if somebody has been very ill and vomiting quite a bit, you might see erosion to that level. So these are things that you might find commonly. If you do see these things in somebody's mouth, let's make a referral and let's get them healthy. Okay? So these are our key takeaways when we talk about our pregnant patients or people who may become pregnant, patients who may become pregnant. We want to start talking about oral health now, because when you become pregnant, there's a whole lot of information thrown at you and things that you need to consider. And so it's better if we can kind of set the stage for it early and then remind when we're actually in the trenches of pregnancy. When we wait to seek treatment, it may be too late. Mom's oral health absolutely impacts baby's oral health, and it is safe and necessary to get dental care. That is my biggest take home. It is safe and it is necessary. Okay, so we've had our babies, and now here comes this beautiful baby. When we do a risk assessment on a baby, we don't assess risk on the baby. We assess it on the caregiver. Typically mom, it could be someone else. Does anybody know what's wrong with this beautiful picture? What do you think? She's kissing the baby on the mouth. That's exactly it. Now, again, geriatric mother here. I love my babies and I kiss them on the mouth and I'm like, sorry guys, you don't stand a chance. You're getting my you're getting my bacteria. But that's the problem with this picture is when we talk about delay of colonization, those bacteria, that especially those that cause cavities, are transmissible. They are directly transmissible from the caregiver to the baby. So when we kiss our babies on the mouth, when we blow on their food, when they get a little bit older and they want to drink of your big swig out of your straw, they want to share a fork or a spoon, they want a bite of whatever you're giving, that's an easy way to give them the bacteria. Now, the one that I will never do, and this is a sword I'll die on, but I will never lick a binky off the floor. We call them a bootsy in my house, but I have seen parents do that, and that is a direct hit. Or giving my gum and they're like, "Ooh, I'd love some of your gum." I mean, obviously baby's not saying that, but our toddlers, hopefully our babies aren't saying that, right? Toddlers and small children, "Ooh, mom, is that gum?" That's what my 4-year-old asked me. "Is that gum?" I'm like, "It is, and it's not for you." So when we do those things, we're giving them the bacteria directly. So if we have kind of a healthy oral flora, not really a huge deal, right? But if we have any bacteria that cause disease or infection, we can give those to them. So when we talk to the parents, we want to make sure we look at what their risk is. We try to reduce that risk. We try to recommend things like xylitol. Is anyone familiar with xylitol? A few of you are. So it's a sweetener, it's a natural sweetener. What's cool about xylitol is that bacteria that cause cavities, remember how we talked about them metabolizing the foods that we eat and then producing acid? Well, they can't metabolize xylitol. So it basically makes the tooth surface slippery, and then they're not able to create acid when they eat it. Now, what's the problem with xylitol? What was that? You have to have what we call a therapeutic dose. So it's 6 to 10 grams, and we do not want more than that. Why don't we want more than that? Exactly. Some of my students learned that the hard way. We went to a CE course and they had xylitol sugar, like gums and mints and things like that. And they didn't feel well. It can cause GI upset and it can kill your pets. So use it wisely, keep it safe. Keep it away from the dogs, keep it away from the kids, keep it away from yourselves in too high of a dose. But in a therapeutic dose, it's absolutely beneficial and it works very well. So we also recommend that we establish a dental home by the time the first tooth erupts. Does anybody know when the first tooth erupts approximately? Around 4 to 6 months. And which one comes first? This is just for my own trivia. It's your bottom centrals. Yep, typically. So by the time the first tooth erupts, or by age 1, whichever comes first. It's actually within 6 months of when the first tooth erupts. So if we get it between 4 to 6 months, if they're an early, they develop early, that's okay. But we want to try to get them in as soon as possible. So when we recommend that they go to see the dentist, what do you think we're doing at the dentist? Do you think I'm like, let me do my periodontal probing, let me do my oral cancer screening, let me do all those things? I'm not doing all those things. I'm basically trying to look for things like tongue ties. I'm trying to do a risk assessment myself. I'm trying to see if there's any early signs of disease and try to talk to the parents. Basically, I'm just trying to educate the parents. And usually they're asking me questions about teething. I don't want to use topical anesthetics for teething. You can use like a wet washcloth. I like a frozen washcloth. Those work really well for them to chew on. We need to avoid teething tablets, jewelry, all those other things too. And we can talk more about that if you have specific questions. Find me later. When we get to the toddler stage, also, those kids are little wreckets. If anybody's had a toddler, you know, what do they do all the time? They're learning how to walk, and what do? They run into things. Everything goes into our mouths. We also crash into things. We hit ourselves, we hit our mouths, we hit our heads. We're like, gosh, should we put these kids in a bubble because it's dangerous? So we want to just be aware that we can still damage baby teeth and watch for signs of damaged baby teeth. Basically, they'll darken. We'll see that in older kids too. When we talk about diet, we shouldn't be just nursing continually if our parents are nursing. We want to make sure only water in cups at night. I wish I didn't even have to have this conversation, but it is something I see all the time. Have you had any children come in with anything besides water in a bottle or a sippy cup? And that's just par for the course, right? And that is a perfect recipe for a lifetime of decay, basically. We still want parents to brush as soon as those teeth erupt. We even want them to floss if the teeth touch. So my little guy who's 4 now, when he was born, he got his first 2 little baby teeth. And wouldn't you believe it, they were little snaggle teeth. They were crowded and touched, and I had to floss when he only had 2 teeth. And I thought, this is only going to happen to a dental hygienist because I'm the only person that's gonna floss these teeth. I also wrestled with him daily, twice a day for 18 months before he finally let me brush. I can confirm that he is a great brusher now, but I thought, I have a whole newfound sympathy for my patients. We do recommend a fluoride toothpaste. We do not have fluoride in our water here in Idaho, essentially. Very little, few pockets of naturally occurring fluoride, but usually not at that therapeutic dose. The only place that we see it is in Mountain Home, and it's on the base. They have water fluoridation. Northern Idaho has a couple spots where they're working on it. So really not much fluoride in the water here in Idaho. Varnish applications, a fluoride varnish. Has anybody used fluoride varnish before? A few of you have. Fluoride varnish is great. It's actually recommended that you apply fluoride varnish. It's recommended that I apply it. And too much of a good thing really isn't a bad thing with fluoride varnish because it lasts for about 3 to 4 months. So even if I gave it to them, you gave it to them yesterday and I give it to them today, it's not going to hurt them to have those. It's just not going to have really a therapeutic benefit because they've already kind of maxed out on their fluoride uptake. And then we should also be looking at supplements. So I do have a slide about fluoride later that we'll talk a little bit more. And we won't get too hard into it, but no pacifier by age 3. Why do you think I'm worried about pacifiers? Absolutely, it changes the structure of the mouth. And then we're seeing a lot more research with things like airway and those types of things, which we won't get into today. Again, this is top level, but things like that we really want to consider because it can change the anatomy of the mouth, the structure of the mouth. It can also affect speech and development too. So look at the parents, look at their risk assessment, look inside the mouth. A knee-to-knee exam is fantastic for kids. So do you know what I mean by a knee-to-knee exam? Basically, the parent holds the baby or the child facing them, and we sit with our knees facing each other, and then they'll drop the baby's head down into my lap, and then I can look and see what's going on in there. Are all children super cooperative with that? No, only in our dreams, only in our dreams. But a lot of times we can at least get a quick look, and the parent can help us to kind of hold them and hold them still so we can at least try to look in there and look for anything really, really glaring or really obvious. So this is what I should be looking for. I didn't trick you on this one. I said, this one's a healthy mouth. This is a healthy teeth and gums in a baby. You can see that or a toddler by the time they're having all these teeth. It's a child with a full primary dentition, but you can see that the teeth are smooth in color and texture. They don't look rough. The gums look like there's no really redness, swelling, bleeding. This baby on the right, you can see some of that splotchiness on the enamel. Those are signs of early decay. Early childhood caries is what we call it when we see young children with a lot of decay, especially in their front teeth. It's usually related to liquid sugars, basically. So whether that's prolonged nursing, using a sippy cup with anything besides water, things like that, that's usually when we see those types of things. So if you see anything on the right, you should be making a referral immediately so that we can try to mitigate that risk. And I will say this child on the right, this isn't to the point where we would have to do fillings. There's things we could do that are non-invasive and be able to kind of nip it and remineralize and do what we can to keep them in a healthy state until they get their permanent teeth. So long story short, baby teeth matter. They're important. We need them to hold space for the permanent teeth. They're important for development. When we talk about things like speech, they're important for us to convey emotions. And children still have psychosocial effects from having like a mouthful of silver fillings. There's a reason that Medicaid pays for a tooth-colored crown on front teeth, even in children. And that's because of the psychosocial effects of having just stainless steel crowns on every single tooth. And it's not like Medicaid's like, we have a lot of money and we're feeling very generous. I mean, they're doing it because it's a significant effect with a psychosocial effect. So it's important for those baby teeth, not just because they hold the space. If we have to get rid of them early, we need things like a space maintainer because those baby molars are going to stay in the child's mouth until about age 10 to 12. So that's a really long time. And they get them around age 2 and 3. So they stay in there for a long time. We want to maintain them while we can because they're important for us to be able to maintain space, improve development, and things like that. So then we talk about our adolescents. I like this picture because this is actually my own child here on the left. He's a man now. He turns 20 this year. I told you I'm a geriatric mother. My children were not planned that way. I had a couple of accidents. It's not my husband's first child with the new one either. It's just getting a few surprises thrown at us. But this is the one who really turned me into a mom. Taught me how to be a mom with some of my favorite kids. These kids were sleeping on my trampoline and I forgot to turn off the sprinkler system, which is why they look that way. But I love this picture because it really epitomizes adolescence, right? This is adolescents at their finest. They got their bag with their baseball bats on it. They're ready to have fun. They're sleeping on the trampoline. It was a great summer for them. Now, my problem with adolescence is that I'm still assessing disease status and risk, but I'm not focusing on the parents anymore. Why aren't I focusing on parents anymore? These kids are doing a lot of things themselves and they're making their own choices. And sometimes we question those choices because their brain's not fully developed, right? But we're looking at these kids, they're making their own dietary choices. So we want to be seeing like, what are you doing? Not what does your mom think that you're doing? What are you actually doing? And so when we're working with our adolescents, we're looking at the same types of things that really we look at with infants and toddlers. And actually, we look at the same things with adults also. But we're looking at things like a little bit more focus on injury prevention, right? We're starting to maybe play organized sports. Are we using a mouth guard? Are we doing anything to protect our teeth? I had a patient one time, he was practicing for snowboarding, and he was at like a skate park. He had like a strap on like roller snowboard for when there wasn't snow, so he could do flips into a ball pit. Well, he tucked so hard, he knocked his own teeth out with his knees. And we had to do some major SOS type things to try to save those teeth. So kids need to be talking about things like traumatic injuries. They wreck on their bikes, they wreck on their skateboards, they do things like that. And so we want to make sure if you're playing sports or using a mouth guard, I can tell you right now, most kids aren't. The only time I ever heard anybody say anything about a mouth guard was when my man-child was playing football, and then you got the little bite block. So talk about those types of things. Talk about their oral hygiene. Most of the time, the parents are not supervising their oral hygiene. They'll say, go brush your teeth, or did you brush your teeth? But the parents aren't usually checking to see if they actually brush their teeth. We still recommend things like fluoride varnish. We might be looking at how the teeth are developing, referring them to an orthodontist. When we talk about the way that the mouth forms, we see a lot more crowding. Almost everyone benefits from seeing the orthodontist. They want to see them by age 7 at the latest, because they are looking at more things. They're looking at airway, they're looking at development. And if we see the orthodontist earlier, they're able to actually do some, they call them guided extractions, where they might be able to do braces in like 1 phase instead of 2 phases, so that the mouth can have more room to develop as it grows and develops. We also know that with kids, we still have psychosocial concerns. So when we get to be in about middle school, if anybody's had a middle schooler, we know that our middle schoolers start to pay attention to maybe their hygiene. If they're on one end of the spectrum or the other, they either do not care about their hygiene at all, or they have started to really pay attention to their hygiene because they've discovered a romantic interest, or other people are paying attention. And so it's a good motivator sometimes when we get into middle school and we're like, oh, your teeth look so dirty. Maybe this is a good time for us to motivate brushing every day. That same issue, though, is that we also sometimes see influence from other children with things like alcohol, tobacco, vaping is huge. And we see oral effects of those. So we want to be kind of monitoring for those types of things. And then what we like to do on our end is we like to do sealants on the teeth. Does anybody know what a sealant is? Yep, it's a resin that we put on the biting surfaces of the tooth to prevent cavities. So we call it a pit and fissure sealant. And essentially on the biting surface of your tooth, you have lots of grooves and pits, and some people have really deep ones, and some people's aren't too bad actually. And so we recommend those to prevent bacteria from getting deep down in those crevices that we're not able to clean very well. So we like to see those as soon as the teeth erupt. So we usually get our first molars around age 6, and your second molars around age 12. So we want to make sure that we're getting those sealants on as soon as possible. That's on our end. We won't ask you to do that, but if you can make that referral, that'd be great. The other thing that we also find with adolescents is this study that was first published, it was in 2012, where they talked about basically treating and preventing dental problems can really benefit children developmentally and academically. And they actually did an update to this study in 2019, and they had the same findings. They said, yeah, this is still really important, and it reinforces the need for us to be able to focus on this. So it's not just, physically, but also mentally can have an impact. So when we talk about our kids with our adolescents, make sure, I'd say the big take home is that the habits and the decisions that we make in adolescence impact their adult dentition for life. We get our first permanent teeth. It feels cruel and unusual, but we really get our first permanent teeth around age 7, 6 and 7, and we have those for the rest of our lives. So we talk about people living longer, living healthier or unhealthier, depends on the day and who we're talking about. But we have those teeth and they last us for a lifetime, and we get them around age 7. And so that's why it's so important for us to focus on adolescents, because the decisions that they make related to their teeth, or that we as providers are helping to influence, it matters for the rest of the lifetime of their dentition. So we'd be remiss if we didn't talk a little bit about some of these social determinants of health. I know our speaker last night, I was able to catch the tail end of our speaker about hypertension last night. So we talk about social determinants of health, and it's important to know that when we talk about disparities, they don't just affect children or adults, but it usually is everyone that's affected by these things, but they're usually amplified when it comes to adults. Part of the reason is because we have a lack of access or cuts to programs for adults. So there was a huge stink about adult Medicaid, right? It was something that just came through. We had dental benefits for Medicaid for adults, and there's always discussion about that being cut. It was something that we voted on as a state. It was important to us as a state. They were able to get these benefits in, and now it might be something that gets taken away. Why would we do that? The mouth is connected to the rest of our body, right? But that's why we're spreading the message, right? So when we talk about our adults, it's usually just like amplified. One of my favorite like tweets that I've seen about oral health is it says something about, why are teeth these luxury bones in my body that I have to pay extra to keep? And I'm like, you're right. That's basically what they are. They're like these extra luxury bones. And when you look at someone's mouth, it can be, unfortunately, it can be indicative of their socioeconomic status, right? Because they are these luxury bones that only rich people can afford to have. And that is a huge problem with our healthcare delivery system. And when we talk about people having access to care, it's not always just that we're in a dental HIPSA area, although more than half of our state is. When we talk about access to care, the biggest barrier for access is what? It's financial, it's ability to pay for it. And it is extremely expensive. And I can tell you that I know a few dentists getting rich, but most of us aren't getting rich. The products that we purchase are very expensive. Our operatories are extremely expensive. I work at a university setting. You would die if you knew how much it costs. And that's at our school pricing. That's like bottom of the barrel pricing for a lot of things. It's so expensive for the equipment. So I'm not saying anybody's the bad guy here. It's a multifactorial issue, but we have to be able to do things to be able to get people the care they need as soon as we possibly can, to make things treatable when it's less expensive, whether that means taking off from work, recovery time, also the cost of care, things like that. We want to be able to get in early, because we know that most people, every person 19 or older without medical insurance, there's 3 people that don't have dental insurance. And you guys are probably seeing it on this medical side too. So the same considerations that we had for kids are the same considerations that we had for adults, basically, except that with kids, if it's in their primary teeth, they are important. We want to keep them as long as possible, but we almost get a second chance, right? Because those teeth aren't meant to last forever for most people. Some people retain their primary teeth, but that's unusual. Most of the time, we get a fresh start. Things like gum disease, our body is able to repair itself if we can kind of remove the infection, and the body is able to be like, hey, no harm, no foul. We had some gum inflammation, but we're not seeing the bone loss associated with it. So nothing permanent, right? It's all recoverable. But with adults, that's not really the case anymore. Does anybody know what the #1 risk factor is for periodontitis, periodontal disease, gum disease? #1. Smoking. You guys are smart. So smoking is a huge factor that we want to talk about. We're trying to teach my colleagues to talk about it too, connect with cessation information. I can tell you, as somebody who's lived with a smoker, I was like, I don't know any smoker that's like, gosh, I'm really glad that I started smoking. I love smoking every day. It's the best. It's an addiction, right? So we try not to harp on them too much, but I can also tell you as a professional, when I speak to my patients who smoke, I just make sure they know the information. I ask them if they're interested in cessation information. Usually they're like, not today. I say, that's fine with me. But every once in a while, they surprise me and say, hey, I think I want to learn more about that. And I'm like, oh, I don't know what to do now. Okay, I do know what to do, but I have to get my head in that space, right? So I'm like, oh, have I got news for you? There's lots of programs available, lots through your public health departments, through the state, where they can get like nicotine replacement therapy and all sorts of other things as well. So anyway, keep that in mind when we're talking about it, because smoking is the #1 risk factor for perio. We still see people with cavities. We see a higher risk of oral cancer. So typically somebody who was at a high risk for oral cancer it was usually a white male, over 55, heavy smoker, heavy drinker. But that's not the case anymore. We see HPV-related oral cancer frequently, coming more frequently in younger populations, people who were not at risk. So as healthcare providers, something I'm trying to teach our medical team or our dental team to ask about as well is HPV vaccination. It's a cancer prevention vaccine. We want our males and females to be having that. My children have all been vaccinated. I've been vaccinated because it's a cancer prevention vaccine. Is it the ultimate? Is it the best? No, but it does also implicate or it can help prevent oral cancer when it's HPV related, which is something we're seeing on the rise. And then, of course, our chronic conditions. There's a whole bunch of chronic conditions that are related to oral health. They have usually an inflammatory relationship with those. And so that's usually what we see with the, it's inflammatory cytokines that we typically will see as the relationship between these infections. And here we go. Once again, all of these different conditions that you can learn more about. For the sake of time, we won't go too deep into them. Now in our older adults, those are people 65 or older, same things as adults, except we just see like everything's ramped up. We see higher incidence of disease, of course, because time comes into play. When we do see tooth loss, that's one of our big concerns with older adults. Does anybody work with people in like in nursing facilities and things of that nature? Some of you do. So I like to go into our nursing facilities. I have a couple in Pocatello that we have great relationships with. We utilize teledentistry for some of them. Others, we go in for something as simple as like a screening and going in and like doing biofilm removal. So just removing the plaque. I have these toothbrushes that Creston Oral-B gives me with their power toothbrushes. They have a disposable brush head that I can use a fresh one and disinfect it in between each patient and have fresh brush heads. And they have like a sheath that goes over them and everything. And we go in, we do screenings. It can be very simple. I mean, we can use disposable mouth mirrors and gauze for those types of screenings. And then we also do things where we have all of our equipment and it's totally portable and totally mobile. And by totally portable, I mean, you have to put your back into it to move everything, but it is technically movable. So we have ways to try to reach these populations because when we see our older adults, what I see is a lot who have lost their teeth, their dentures don't fit anymore. And then that of course impacts nutrition, it impacts their ability to heal, and everything is just kind of amplified. So poor oral health really is something that impacts a lot of people. In Idaho, we see in our older adults, we're not as bad. The South, no surprise here, the South tends to have generally not as much of an emphasis on oral health, just kind of culturally and some other factors that go into that as well. We're not too bad in Idaho, but we can still see our percentage is in average in the US is about 30%, 32%, and we're kind of right in that average area as far as tooth loss, 6 or more teeth, due to specifically cavities or gum disease. And so you can see we're not great in Idaho, we're not the worst, we're right on track with the national average. But when we see these types of things, poor oral health is something that impacts everybody in every aspect of their life. So when we talk about somebody with a mouth that looks like this, it can impact their ability to speak. It can touch, taste, chew. If they have an infection in their mouth, usually they're used to it, whether it's a child or an adult. We see a lot of children where we are looking at things like behavioral issues, and what we're finding is maybe untreated disease. Kids can live with abscesses. I see kids with big old abscesses sometimes, and I'm like, how are you coming to school every day? And they're not sleeping because they're just used to that chronic pain and nobody's looking. It's because nobody's been looking at their mouth until I go into a school and I'm doing like a school-based program and I'm like, oh my gosh. And luckily, because we are trying to improve access so much, I don't see that like I used to a decade ago, but I do still see it. So when we see people with these types of things going on in their mouths, they're usually used to it. They're used to the pain. Has anybody here had a toothache? A few of you? I had my first toothache, it was a while ago, but I was like, what in tarnation? I had a bunch of other things going on. They thought I was making it up. They were like, Colleen, there is no way. And I was like, dude, my tooth is loose. I've got these things going on. It was the worst pain of my life. Couldn't decide if it was from clenching. Was it my jaw? Was it my temporomandibular joint? Was it all these other things? Basically, the tooth was slowly dying and it was the worst pain of my entire life. I lost bone around the tooth within 2 weeks. I took x-rays. It was like wild. And it gave me a whole new appreciation for people living with tooth pain every day because it is rough. So when we see people like this, they're just used to this pain, they're living with this chronic pain, but it affects all aspects of life. And when we also talk about these things, do you think it's easy for someone whose mouth looks like this to get a job? Not if it's a front of the house job, right? Or you're forward facing with the public, because we, for some reason, we put somebody having a healthy mouth or a nice smile, we kind of associate it with morality, right? This is a good person, this is a whatever. But if they have a mouth that looks like this, we don't say, gosh, this person has untreated disease. We're thinking, oh, something's not right with this person. And that's really not the case. So it makes a huge impact on people. When people's mouths look like this, they're not usually showing as much expression. Smiling is like the universal language, right? They're not comfortable smiling because they're embarrassed of their mouth. When they find out that I'm a dental hygienist, the first thing people do is go like this. I'm like, too late. I've already diagnosed you from across the room. You're too late. But I try to be extremely empathetic to it because I know we didn't just get here overnight. So when we think about these things, these all have repercussions on a person's mental health. So what is the relationship between mental health and oral health? Well, it's kind of bidirectional. So we know that depression, anxiety, substance use disorders, those things can all have a negative impact on a person's oral health, and vice versa. If somebody is experiencing these things, there's significant oral disease risk. So it can be nutrition related, when somebody's in the thick of depression, depending on the individual. It can be, our nutrition choices aren't the best, right? Usually like a high sugar type diet, maybe frequent snacking. Sugary drinks are huge. Substance use, depending on the substance. If you smoke, we already talked about that being the #1 risk factor for perio. Depending on what else they use, just devastating effects. We can see, has anybody seen anybody with like meth mouth was the term that we'd use? So like basically rampant decay, usually associated with meth use. I see mouths that look like that when they are using energy drinks frequently, or Mountain Dew, sometimes not even ever a history of meth use, but I see the same things from soda and energy drinks. Of course, we have difficulty accessing care. If you're having a hard time getting out of the house, you're surely not like, hey, let me call Dr. Stephenson here and go get in and get my teeth looked at. So it definitely has a relationship where one can impact the other and vice versa. And it can also create issues with self-esteem. There is a stigma associated with mental health, so they don't always want to talk about it. When they come see us, we might see things like dental phobias or really amplified pain perceptions. So I'll have patients, especially if they're nervous, to come in to see us, and they'll be like, and they're cringing. And I'm like, I literally haven't even touched you yet. Like I literally just put on my gloves. I haven't even touched you yet. So we need to be aware of those things on both sides of the dance space, basically. And then what we also notice, one thing I really notice on my end, is that a lot of times the medications that are used to treat things like anxiety and depression have xerostomach side effects. So dry mouth is rampant. And when I say dry mouth is rampant, what I mean is sometimes people are taking multiple medications. Any medication can affect not just the quantity of saliva, but also the quality of your saliva. And it has a compounding effect. So it's not like I'm taking one thing and it causes dry mouth and my mouth is just dry. It's like I'm taking one thing that causes dry mouth and then another thing and it's even more dry and more dry and more dry. And it can have devastating effects because our saliva is naturally a buffer and naturally a cleanser. So if we don't have adequate saliva, whether it's the adequate amount or the quality of the saliva is not able to buffer at the level that it needs to, that's when we see dental disease. So when we see patients with these types of things, we see shared risk factors as well. And it's important for us to be able to make referrals and try to work together as a team to say, hey, how can we get these people who are experiencing challenges with mental health the care that they need that is most appropriate. Here's an example of something you can use. I've interspersed a few different QR codes to link you to things if you want to learn more about them. I did check them all. They all worked on my end. But this is actually a toolkit that was created that helps to coordinate care and integration between mental health and oral health. So these are just some examples of some of the things that you might see. So like mental health impact on oral health, it lists some examples, same things with like cognitive health and vice versa. So a really great tool for you to be able to use if you're interested in learning more about that, or that's something that your practice looks into. Now, shifting a little bit, when we talk about cancer, we see a lot of people who are experiencing cancer treatment. And really, the biggest issue with cancer treatment is that we want to treat people before it becomes an issue. So if we know that somebody's been diagnosed with cancer, we want to make sure on our dental end that we're seeing them immediately so that we can assess risk. We can make sure that we clear up any infection. Remember, periodontal disease and caries are infections. We want to make sure that we treat those infections before they go through any type of cancer treatment, because we know how devastating it can be to the body. So some of the things that you might see with somebody experiencing cancer treatment, these are things we might see more on our end, but we would see things like inflammation of the mucous membranes. We want to prevent that before it even happens. It can be extremely painful. It impacts nutrition. You know, if their mouth hurts terribly, they're not able to eat and get the nutrition they need. We can see an increase in infections, opportunistic infections, so viral infections or fungal infections. We see obviously major issues with dry mouth, and then taste changes. So of course, things don't taste good, or it tastes gross because of the taste changes that have occurred from the medications that they're taking. And so not wanting to eat as a result of that. We'll see neurotoxicity. So basically what that is it's basically like a toothache. It's that persistent aching, deep pain, but we cannot find any dental or mucosal cause of it. So they're having like this horrible pain, but we can't find an actual cause that has created it. And we know that it's a side effect of certain classes of drugs, like vinca alkaloids are notorious for causing that type of thing. And then of course with mucositis, that's like mouth sores throughout. So the other thing that I'll just briefly touch on would be like osteonecrosis. So if we're not treating disease before it occurs, if we reach a point where we have to take a tooth out because it is too decayed or too much bone loss around it from caries or periodontal disease, then we have a higher risk of osteonecrosis if somebody has taken chemotherapy medication or had radiation. And if anybody's familiar with osteonecrosis, is anybody familiar with it? I don't have any pictures of it in here, but it is gnarly, it's wild, it's extremely painful, and basically we cannot get great healing as a result. So we want to get rid of those things before, because they have a lifetime risk associated after they've had radiation especially. So this is what we recommend, basically treating any pre-existing disease. We want to perform any dental treatment ahead of time. On my end and your end, we want to look at any medications that you take and assess them for the ability to dry out the mouth, because we need that saliva. It's important for us to have. We want to implement fluoride therapy. So we can make custom trays where they have fluoride delivered that way. We can make a system where we're using the varnish regularly. We can have them using a prescription fluoride toothpaste at night. And they make some that are specifically like for dry mouth. They don't have any foaming agent and things like that in it. So it doesn't, you know, kind of exacerbate the soreness if we do already experiencing some of those things. And then we also want to advise about any type of smoking or alcohol cessation if there's a problem with those. Both of them have drying effects on the mouth, among other things, and we don't want that to occur. So we want to make sure that we are talking about them with them pre-treatment. Now, during treatment, it's super important for them to come in and see me. So I want them to have regular appointments with their dentist or dental hygienist, ideally both of us, and really talk about maintaining their periodontal disease status. We see cancer, typically, we see them in all ages, of course, but when we see it in older adults, usually by the time we're older adults, we also have some type of periodontal disease history or something like that in the past too. So hopefully we've gotten them to a healthy state beforehand, but we have to see them regularly to maintain that. So we want to make sure that we're maintaining that as much as possible. We're able to assess for any signs of infection or inflammation and things like mucositis and treating it immediately instead of letting it get worse. And then we also want to make sure that we're providing any type of supportive therapy. So if they're saying, gosh, my mouth is so dry, what can I recommend to help alleviate that? And there's lots of different things on the market. Some are better than others. If you actually needed like a list or anything like that, I can happily connect you to some resources. There's some things that I really like for my patients. I'm not sponsored by any of them. These are just things that I recommend because my patients have had good results with them as much as possible, considering that they're in the thick of cancer treatment. So these are easy things that people can do, making sure we get enough water, obviously, sip it frequently. I do see a lot of patients. I see this also in individuals with chronic kidney disease. We have extreme dry mouth when they have chronic kidney disease. And so they like to suck on a hard candy because it stimulates a little bit of saliva and salivary flow, except that a lot of times they're choosing like sour candies, which are acidic. And we're also seeing full sugar candies like a Jolly Rancher. They're a little bit sour and they're also full sugar. What does that do for caries risk? It's like through the roof. So if they're going to be sucking on those things, ice chips are great. I mean, obviously they don't have any flavor, but it does soothe. It gives us some water. It helps on that level. Obviously, somebody with chronic kidney disease, I'll let you be the expert on that with intake, water intake. But sugar-free candies are great for those types of things. And especially if we can get one with xylitol, as long as we're being careful with that therapeutic dose and not getting too much so that we have GI upset. Sugar-free gum's great too. Now, this is an interesting one, avoiding glycerin swabs. Do you know why we avoid glycerin? It actually dehydrates the mucosa. So it actually exacerbates the problem. It might seem like it's being helpful for a minute. That's something, it's kind of an older school thing. I've worked with hygienists who have been like, oh, we'll bring glycerin in and we'll practice using that, especially in like our nursing facilities, skilled nursing facilities, with patients who are not able to care for themselves. And now we're saying, actually, glycerin's not the move. It dehydrates the mucosa. Some of the saliva substitutes or like gels, you can have prescriptions that stimulate salivary flow. And like I said, there's some over-the-counter products that are great, that work well. And then we want to just be really careful that we prevent any trauma, because if we do have somebody who's biting their cheek or chewing on their lip or things like that, it can create a sore and then our healing ability is compromised. And sometimes we have to have like a topical anesthetic or an analgesic for the pain. So we have something called magic mouthwash. You're probably familiar with it, and it's basically a compound of several different things that kind of coats the mucosa and also helps to minimize some of that pain as much as possible. But the best thing we can do is basically avoid it happening in the first place. So now let's talk about things we can actually do, right? So in-office treatments and services. There's a whole host of things. These are things that you can do. It's not just me as a dental provider, but what you can do. So this is actually a framework that was created. It was initially Qualis created this for medical providers, and it was actually ideally created for people in a federally qualified health center. Are any of you in an FQHC? A few of you are. So hopefully if you have a dental component, you guys are starting to work together. If you're not, let's get that ball rolling. And I mean on both ends, right? It takes all of us to do it. But when we look at this framework, basically what this is asking you to do is saying like, hey, same things that I've already talked to you about today, which is like, ask about things that relate to oral health. Don't just say like, that's the dentist dance space, not my problem, not my business. And I know that we have a lack of the number one thing, which is time, right? Time is money. We don't have enough of either, myself included, but we have to make the time for it. The mouth is part of the body. If that's what's part of comprehensive care, then we need to be providing comprehensive care. So ask about it. Ask about some of these risk factors. Obviously, they're not only oral disease risk factors. A lot of them are interrelated with other systemic conditions. Look inside the mouth. All I'm asking you to do is look. Take a look. Something seems awry. Decide what you're going to do about it. Can I make a referral? Can I educate them about it? Can I do something about this to move forward and try to get some type of resolution to it, instead of just ignoring it and being like, oh, I didn't say anything, or there's nothing I can do about it. There is something you can do about it. Let's see what we can do to make a referral. And I do have a slide about referrals, so you're welcome. Because that's the number one thing I hear about from medical providers is they're like, super, I looked in the mouth, I found all these things. Now what do I do? Like, where do I send them? And people's health literacy is like notoriously low, right? Having difficulty accessing services. And one thing I like to think about with resources is that a resource that people aren't aware of isn't really a resource at all, but there's lots of resources and things that we're working on. So I'll give you that soapbox speech in a few minutes. If you do see patients, whether it's children, whether it's adults, fluoride is the move. I know that fluoride is too much of a good thing isn't always wonderful. Fluoride's one of them, okay? Fluoride can be something that is a little bit controversial depending on where you're at, depending on your thought processes. But essentially, if you want people to not get a mouthful of decay, we have to use fluoride. It's the best thing that we have right now. There are other things on the market if somebody is just like adamantly opposed to it or truly contraindicated. So sometimes if we have somebody with like a thyroid disorder, we may need to be a little bit more cautious about the amount of fluoride we use. But in a general patient, fluoride is important. So in fact, it's so important that they used to say, we don't want kids under 3 to have fluoride because they're going to swallow it. And now we're saying, you know what? It's okay if they swallow a little bit. They're usually not getting the therapeutic dose of fluoride anyway, systemically. So now we do a smear the size of a grain of rice for our kids under 3, and then everybody over 3, we do a pea-size amount. We don't do the big Aquafresh swirl, although it is beautiful. And again, as someone born in the 1900s, I remember those commercials and it was motivating, right? Aquafresh really made the move with that. I'm sure they sold a lot of toothpaste because people were like, yes, putting a big glob of it. But really all we need is a pea-size amount. Any more than that is overkill. You're wasting your money and your toothpaste and your fluoride. You don't need it. So a pea-size amount is perfect for everybody over 3. We do have a lot of people who are high risk in our area. We follow something called CAMBRA. That stands for Caries Management by Risk Assessment. And basically, it's evidence-based guidelines where we look at somebody's risk of getting cavities. So like with children, like little kids, toddlers, infants, we're looking at the parent. With children, adolescents, and adults, obviously, we're looking at individual habits. But we look at their risk of getting cavities. This is on our end. And we have these evidence-based guidelines that we recommend and that we follow for fluoride. So if they're a high risk, we might recommend anybody 6 or older, we recommend a 5,000 parts per million fluoride. So again, not sponsored. These are just some brands like you can do a generic sodium fluoride, 5,000 parts per million. We use Prevident, we use ClinPro 5,000, Prevident 5,000. Those are the 2 big brands that I see all the time, but you can get generic sodium fluoride in 5,000 parts per million also. If somebody's just a moderate risk, we usually recommend, again, everybody gets the fluoride toothpaste. Go ahead. Yes, it absolutely can. Good question. Yes, so the question was, can that be prescribed through a family practice, not just a dental provider? And the answer is yes, you absolutely can. And in fact, I'm going to depend on you because, again, lots of people aren't seeing the dentist at the frequency they're seeing their primary care provider. So if they are a high risk, absolutely a daily toothpaste. The way I like to use it, I don't feel like it cleans as well. Usually they don't have the foaming agent in them. I use one every day because I was getting a lot of recurrent decay. Also, my big man child, who's almost 20, he had a bunch of cavities started. I'm a believer in the fluoride because I saw a bunch of cavities started because I told you I already confessed my sins that I kissed my babies on the mouth. I was like, sorry, kids, you don't have a chance. And I will share my straw with you. But just forgive my sins. When I do that with my kids, though, I'm like, I'm giving you my bacteria. Let's hope you get your dad's because he doesn't have a lot of cavities, but unfortunately, they got mostly mine. So Connor got on that prescription fluoride. I had teeth taken out for ortho. And I was like investigating them. We got to keep them. And I'm looking at them. I could see where cavities had started on those teeth. And I could also see where they had remineralized. And I accidentally cracked one in half. I was like, this is a case study. I keep it in my drawer in my office so that I can show my students. And I'm like, look at this. You can see exactly how the decay had started through the enamel. Halfway through the enamel, it had remineralized. He never had to have a filling since. So big believer in the fluoride, but you do have to use it regularly. For myself, same thing. I would go and I'd have recurrent decay or new decay. And so I started using it just once a day. I brush and floss like I normally would, brush on it at night. You spit out the extra, don't rinse, and then you're right as rain. If they're a moderate risk, you can recommend like an over-the-counter. So like ACT is one of the best known brands that has fluoride in it. They can do a mouth rinse with ACT or any generic. Big fan of a generic. Just look for the sodium fluoride rinse. For those moderate risk cases, anybody that's high risk, we need to be doing fluoride varnish. So like I mentioned previously, fluoride varnish should be done every 3 to 4 months. What I'll do with a patient, if they're a really good patient, about coming in every 6 months, which by the way, 6 months is an arbitrary number that was created like for a commercial, for an advertisement. It's an arbitrary number that was made. Some people need to be seen more frequently. Like our patients with diabetes, poorly controlled diabetes, I might see them every 2 months. It takes about 8 to 12 weeks for the bacteria in the pockets to reproliferate with poor oral hygiene. And so some of my patients with I had a patient with type 1 diabetes that was just out of control and she could not get good control. And so we saw each other every 2 months. And then some people, I don't even need to see them every 6 months, to be honest with you. You can. So like I said with fluoride, too much of a good thing isn't always wonderful. You can get too much. So that actually leads us to our systemic fluoride here. These are the U.S. Preventive Services Task Force recommendations for fluoride based on age. What you have to find out is what is the fluoride content in your water. So when we're talking about fluoride for people, there I've linked, I should have made a QR code for it. Go ahead.
I already checked. They have no, water supply is the only one they have surprise for.
And
That was one of your links.
oh, perfect. And is it one? And is it at the 0.7? I think it's 0.7 parts per million.
That's, it's the Eagle water supply was the only, there was listed probably about 23 of them.
Oh yeah. And you can look up like your exact address. So like I said, I'm from Southeast Idaho. I can look mine up exactly and find exactly what it is in the area that I'm in. But you do have to do a little bit of math that way. Most people in most places in Idaho don't have it at that 0.7 therapeutic dose. So that's why we have to, or is it I think it's 0.7. I would not pass boards if I was taking this right this second. My students would giggle at me. I'd have to look it up, but it says exactly how much it is. So if they are not at that fluoride level that we want to see in the water, then these are the prescription recommendations. And
City of Eagle website says do not add it to water.
naturally occurring. Yep. There are only, like I said, Mountain Home Air Force Base adds it. So community water fluoridation, that's a topic for another time, and we could spend 3 hours talking about that. But generally in Idaho, if we do have it naturally occurring, it's not at the level it needs to be. And there's only a couple places that have community water fluoridation, and it's not right where we're at. So we do recommend as a primary care provider that you do make those prescriptions. And in fact, my pediatrician, for my little guy, he is an excellent pediatrician. I love him. David Larson, shout out to you from the Pocatello Children's Clinic. I think he's a wonderful physician. He asks all these questions and he asks these things. Obviously, probably not as in depth with me because he knows I'm a dental hygienist and we talk shop, but he did not, I am throwing him under the bus a little. He did not ask me about fluoride supplements at Canon's 6-month appointment. And I didn't think about it until I went home and I went, oh, I didn't talk about fluoride supplements. So I called, talked to the nurse, and she said, oh yeah, he can do this for you. And I said, well, I would like to encourage you, according to the American Academy of Pediatrics, to do this, blah, 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 blah. And I would be happy to talk to you more, and here's some resources. So trying to talk to them, thank you for doing it for me. I'd like you to do it for everyone, basically. And is he doing that? I don't know. I'll have to check in at the 4-year-old visit. So, or the 5-year-old visit. So these are things that you can do on your own. Make these recommendations. Absolutely. You have prescriptive authority. This is definitely in your wheelhouse. Look these things up. These are American Academy of Pediatrics and U.S. Preventive Services Task Force recommendations to be able to do these things. These are how much they recommend for how many parts per million naturally occurring. You might have to do a little math. It can help you. This My Water's Fluoride is extremely helpful to look that up, like down to the zip code address. We even have in Pocatello, like there's a manufactured home community that has their own well source. It even has them on that list. So it has lots of things that way. Usually when they get a little bit older. So you can see, you can take them all the way up to 16 years old because those tooth buds are still developing. In fact, we're born with all of our tooth buds. We just don't really see them. And so with the baby teeth, when the baby teeth are in the mouth, the permanent teeth are forming, and that's the time that we want to have the fluoride. So once we get up, but we don't always see a lot of kids past age 7-ish. It just kind of depends, but it does recommend up to age 16 because we still have like our third molars, for example, forming. Yes.
There's a lot of research done now about neuroplasticity, chronic exposure, as well as mitochondrial dysfunction and that. A lot of
I won't spend a lot of time talking about it, but this was the question. So she said there's been a lot of research. Well, there's been a lot of interest in neurotoxicity related to too much fluoride. Does it affect cognitive development? And I've seen those studies too. I will caution you that the studies that were published are not great and can be refuted. And again, this is a topic for another time, but we do have people with legitimate concerns because too much of a good thing isn't always wonderful. So one thing I will emphasize here is that topical versus systemic fluoride, are two different things. So topical fluoride is on the tooth surface. That is, I want to use that as soon as a tooth erupts, okay? I don't need to be using a smear under 3 if they don't have any teeth yet. But as soon as they have a tooth, I do want to be using a smear of topical fluoride, because once the tooth is erupted into the mouth, it is exposed to all the things, which can essentially can cause decay. So topical fluoride is a huge benefit for people. Now, when we swallow it, it becomes systemic, which is why we very much limit the amount that we get. I do know people who don't use systemic fluoride, but I will tell you this, if I looked in your mouth, I could tell you if you grew up here or not, based on the amount of decay that you've had. Because if you grew up in a place with community water fluoridation, you don't have decay. So for me, it's about weighing the risk and the benefit. It is extremely high levels of fluoride that you have to experience fluorosis. We do see a lot of cases with mild fluorosis because, like we talked about, we're getting systemic and topical, and some of that topical can become systemic if our children are swallowing their toothpaste and things like that. However, for me as a dental professional and for my own children, for me, it's worth the risk. I would rather have a little bit of mild fluorosis than a lifetime of tooth decay. So I want them to have that systemic fluoride when those teeth are developing. And then once those teeth are fully developed, I don't need systemic fluoride. Now that is the problem with community water fluoridation, is you still are getting it, but is it a high enough dose that it really is detrimental? I would argue no. Generally, no. And they do make filters and things like that that you can use for it. So we've only got about 5 minutes left, so I'm just going to quickly tell you about a couple other things. I've listed some CPT codes that you guys can use if you wanted to bill for fluoride varnish application in your office. If you use fluoride varnish, it's a paintbrush and a little dish of fluoride. It is easy, breezy, beautiful. Most of them, you don't even have to be totally dry. You just like have them swallow the excess saliva, open up, swoop, swoop, paint it on. If you've ever painted your nails, you can paint on fluoride varnish. If you haven't painted your nails, it's even easier than painting your nails, okay? It's so easy breezy, you can get it and get it on there. The silver diamine fluoride is something that's relatively new. This code was just released in July of 2023. Everyone's like, super, sounds great. How do I use it? It's a little bit more intimidating. I just wanted to show you that with the silver diamine fluoride, this is the before and after. So silver diamine fluoride should not be used lightly. The informed consent is absolutely essential because it stains the decay black. It arrests the decay, but it makes it permanently black. And also it will stain your clothes, your equipment, and everything else. Do I work with students? Yes, I do. I've seen it all. So silver diamine fluoride is absolutely beneficial. So it's absolutely beneficial in young kids with a lot of decay. It's absolutely beneficial in older adults who maybe cannot handle getting treatment, right? Being moved for treatment. So in our like nursing facilities, it is wonderful, but it does stain things black. I would argue that the teeth aren't looking great to begin with on my end, although these ones aren't too bad, but you can see it's definitely a noticeable difference. So it is absolutely essential that you have informed consent and that we're clear on what happens with it. But again, we're weighing the risks and the benefits. So when we do see children with a mouth full of decay, how do we have to treat that as a dental provider? What usually happens? Sedation. Is sedation safe? There's always risk associated with it, right? Kids die of, in fact, when I hear about kids dying in a dental office, it's usually because somebody was doing sedation and not being cognizant of the amount of sedation they were using, or things have gone bad, they didn't handle a medical emergency the way that they should have. It is not without risk. And so again, you're weighing the risks and the benefits. Yes, their teeth aren't going to be very pretty for your family photo, but can I at least stop it and buy myself some time? Absolutely. Yes, yes, and it can be used, and it doesn't always absolutely arrest. So the question was, can it be reapplied later? And the answer is yes, it can be reapplied later as more decay occurs. But what we're hoping to do is reduce the amount of bacteria that cause decay, right? So if we can reduce that bacterial load by stopping it, that is beneficial for our patient in the long term. They can also stop it to buy time and then be able to fill it later. Like maybe the child grows up a little bit more and is able to tolerate care in a regular dental office without being sedated, you know, things like that. So it really absolutely has its benefits, but it is something to be not used lightly because it does have some issues. So I'll just quickly go through some resources. So if you want this slide, I actually hyperlinked everything and then realized you can't see my hyperlink. So I've hyperlinked all of these things. These are some great online resources. I don't get paid by Smiles for Life, but I should because I'm a big fan. They have lots of modules about oral health, and they actually just released one about silver diamine fluoride to teach you how to be able to apply it. Something at my university that we're working on is potentially doing like a hands-on course where we can show people, because we have our students, we have teeth, and we put them in a little mold and we have them apply the SDF and see what happens, and so that we can use it because we use it all the time. This is the Smiles for Life app that you can use. I love the Smiles for Life app. It is something that is utilized to be able to like formulate a diagnosis. There's lots of different pictures in it. So you can be like, okay, what's going on here? What do I think the solution is? How can I treat it? And it's a way for you to be able to do that. There's some other apps listed here. The Brush DJ is really fun because it not only times things for them, they can set timers and reminders and alerts, but they also can, it also makes like age appropriate recommendations from the National Health Services, like website toolkit that are age appropriate for them. These others are more like things that you might see anatomy-wise. Bone box we use all the time to carve restorations, to look at anatomy for our students. Here's some resources in the Treasure Valley. This is all in the slide deck, so you can hit the QR code. A lot of these, some of them are free clinics, some of them are reduced fee clinics, some are federally qualified health centers. The Central District Health, they have a First Teeth Matter program where they do basically school-based things. They're trying to focus on kids 0 to 3. This is some others that do, like the Love Hills does a like a mission-based things. And then we also like the Find Help helps you get there. MCNA is who runs our Medicaid contract in Idaho. Now I'm going to give you the best tip of the whole day, okay? If you have a patient who has dental needs, it's going to run through MCNA Dental. And the number one thing that the patients will say to you every single time is, I can't find anybody who's taking new patients, especially for adults. So what you can do, this came from the horse's mouth, MCNA told us, have them call MCNA. There's a 1-800 number. They can call it and specifically ask for appointment assistance. If they ask for appointment assistance, that requires them to call around and find somebody within the area who will see them. And if not, they'll find somebody out of the area. They will pay for travel, even hotel, if necessary, to be able to meet the needs, because that's what they are contracted to do for the state of Idaho. Now, we do have the Medicaid contract up for bid, but that is something that I have recommended to people from the horse's mouth through my work on the IOHA. And that is something that I've had multiple people tell me has been extremely beneficial. It saves them time of calling, and getting told no. And also it lets MCNA see that we have a problem and we hope we can do something about it. Go ahead.
Any luck with getting, so I have a number of patients with dystonia or their tremorless physical movement, and so they have to be put under, and they're medicated. So our biggest challenge, and we're near the Oregon or rural Fruitland area, is can you use that MCNA for that as well? And do you specify because of how they need to be able to have a provider with that capability?
Yes, you can, especially people with special needs. Now that's the hardest part, is there's not a lot of providers. I know of one, Dr. Brooke Fukuoka. She's based in Twin Falls and she is to the gills with patients, right? But if they can't find somebody who has the room for you, they are required to find it. So somebody who can meet those special healthcare needs, they have to pay to make that happen. Good question. I'll leave this slide up. I'll keep answering questions. This is my contact info. My email is my name. If you want my personal cell phone number, I'll even give it to you. I don't have any rules or boundaries here. Go ahead and find me. Feel free to answer your questions, but all available. And I can definitely help connect you. I was going to also mention really quickly before we get to your question, the Idaho Oral Health Alliance is actually working on a resources page, because that is what we find, is that we can't find people who are taking the patients like, super, this is important. Now what do I do? I can't find anywhere to send them. So what we're finding, we're working on a resource page and can be a resource to help connect as well.
Dave Nielsen, the use of whiteners is very popular. A lot of people are using. Any thoughts or comments as in regards to benefit, deleterious effect to our dental health use of whiteners?
That's a great question. So asking about the effects of whitening, that is what everyone wants. I see people, remember those mouths we saw with like rampant decay that are, the teeth are falling out of their skull basically. Those patients all want whitening too. So everybody wants whitening. Whitening can be beneficial. It depends on as far as an aesthetic purpose. Now, can you over whiten? Yes, you can. It can make the teeth look almost translucent. Does it break them down or make them more susceptible to decay? Not necessarily. But again, this is a case of too much of a good thing isn't always wonderful. The problem is if we do have somebody with decay or untreated gum disease, the teeth, if you have tooth colored fillings, they don't change color, number one, with the bleach. And then two, if you have decay, it can be extremely painful when whatever that bleaching agent is, whether it's carbamide peroxide or hydrogen peroxide, gets in there, it can pulse and be like, whoa, something isn't right. So when we do any type of whitening, we recommend you get everything healthy first and then you whiten after. So can they use too much? Yes. Can they, but is it really ultra detrimental? Not typically. And in fact, it sometimes has a benefit in that the hydrogen peroxide or the carbamide peroxide, if they do have gum disease, it can help to actually, if they have it in the trays and it's hitting the gum tissue, it can help to kill some of that bacteria too. So maybe the gums look a little better. But that being said, it can also burn the gums. So gotta weigh it.
Thank you, Colleen. We're at time, so I'm gonna go, we'll wrap it up now. Thank you
Super.
very much.